Computer. Okay. Okay. So bringing back to what I was stating, EKG could be a screening and a definitive test. And what is the first? Because what are the first thing we have to do? I have to make sure I got orders, just like we were talking about earlier. I need an order. I can't just do this just because I feel like it. Had Emma got into a lot of trouble because the patient was having chest pain. She saw it says chest pain, and she just assumed, she started just doing an EKG on her. Doctor walks in, goes, "What are you doing?" And she was like, "EKG, because he has chest pain." Whoa, when did you? And he said, "When did you graduate medical school?" Remember, he goes, you have to have orders first, right? Or the exact opposite. I've had MAs who the doctor said clearly, "Hey, I need for you to do that EKG." And here's her problem. She was waiting for it to be written down. Patient has chest pain. Patient has a problem. All right. So remember, the order can be also verbal, but of course, write it down. When was the or make a mental note so later after you perform it, you write it down on your medical record that I was given an order verbally at this time by doctor or nurse so-and-so, and then I carried out the order on this and this time. So you're always documenting, because it's not only the protocol, it's also CYA, because if that person forgot, you now wrote it down like, "Hey, I heard it."
Yeah.
Question.
Would it be better to have also the doctor, like, I know they're busy with all their stuff, but have them sign it?
No, they won't. They're like I said, like the getting which is a little side note, getting signatures from your doctor, make sure you get everything together, like a bunch of signatures, and then hit them up at specific times where they feel most comfortable. So what I used to do is when I was a medical assistant and office manager, I go, "Hey, you need to get signed all this stuff done. What time do you want to do it?" "I need 10 minutes tops, doc. Please." "Okay, at 2 p.m. and at 6 p.m. right before I go home or right before I go back to the hospital." "Okay, at 1:55, I gather all charts, I gather everything, and one by one, I have my Post-its, boom, out." And then right after, I do all the calls, right? And then I do also the same thing. Another thing that you can also do, and you could also do electronically, I know there's a side note but it's just as important, especially you guys, many of you will be going out into the world soon. Another thing you could do is like either do it electronically, put a little Post-it, or if you are in a place with a paper chart, put the Post-it right on top, and then put the more stat on top with the chart. Because how many times when I was a physician and a nurse or whatever, they just give me a chart, and I'm like, "What the hell am I supposed to do this? I don't have time to read the whole thing. Tell me what you need from me." And that's the best way. So if you have an abnormal reading, right? The chart, abnormal reading, don't stick it out where everyone can see, the results, but enough to see the name pop up, and that's a signal to the doctor or the nurse or whoever's going to be looking at that, "Hey, this is something important." And remember, stack it all up, because the one annoying thing is if I'm trying to do my rounds, trying to see all my patients, every 5 minutes, the MA or the tech on, "Doctor, can you sign this? Doctor, can you look at this?" And I go away. I got stuff to do, because remember what I told you guys? I can't, multitasking is for the birds. When I'm here with this patient, the only thing I need to be thinking about is this patient. Because if I've got others, I'm going to start mixing things up. That's why for years, you always see the medical and nursing textbooks. They always have like juggling balls or something like that. Did you ever see the medical textbooks? They're always like something juggling. Do not do that. Don't juggle things. It's the wrong way to do things, because concentrate and focus at one thing at a time. So back to what I was talking about. How do we identify our patient in a typical office setting? He doesn't have a band. If he has a band, what do? I take the scan, beep, and it's going to pop up on the screen, your electronic medical records. And also, these things, even this one's old school, but it has a SCSI port, if you see here. EKGs now get hooked up to internet. So you don't have to put in all the data information. You just put in a number or scan it, and everything pops in. But if we're in a mom and pop shop, right? I'm just in a free clinic, right? And I'm using this bad boy, which is like, older than my youngest child. right? So how would you know who that's that? That's that person. I have an order. What are the two ways to identify a patient?
Ask them their name and birthday.
Name is good, but what are the two things that are better? That actually is a screen on the electronic medical records at Inova, which I thought was interesting.
Name, date of birth.
Date of birth, and what's the other one? Last four digits of their social, right? Those are common things. And if you go to Inova, there's a screensaver on their EMR that reminds it, because actually it goes, last time I was in Inova, how many times someone didn't identify my wife? They just came in and goes, hi, how you doing? Right? They didn't look at the, I'm like, hey, even my time, I go, hi, how you doing? Joseph, Joey, Marquez, Mr. Marquez, hi. And then I'm like, then I'm looking at the nurse, this is, and he goes, I thought this was Davidson, it's Marquez, who the hell is Marquez? And then I'm looking, okay, I'll be right back, that was Marquez, right? Or how's this? I always tell this story. I had a Pietro Velasquez, 3 of them. The father, the son, and the grandfather. Guess what I did with the labs? Yeah, I did cholesterol on a 6-year-old. You know how much trouble I got into? And then I had to tell them to come back the next day so I can retake the labs.
I've been eating too many chicken.
Right? And then the lab knew they messed up, but you know what they did? They just wrote QI, and you got to call them back in. And then my doctor knew exactly what happened. You fudged up, and she almost docked my pay. I remember, and I wasn't a rookie. I was already an MA for a good year when I did that. Why? I'm trying to do all 3 of them at once. I'm trying to be clever. But I wasn't. I should have did one at a time, one paperwork at a time. So identify who he is. Then I have to tell them who I am. Hi, Mr. Marquez. My name is Nelson. I will be your tech today. Dr. Cassidy wanted me to perform an EKG on you. Is that all right? Have you had one before? Right? You see what I'm doing? I'm garnering the rapport. And you even see what I'm doing. I'm already leaning over. Because how is it? If you're like walking like this, you know how intimidating that is? Especially if you've even been in bed. A lot of times, especially for my more pediatric patient, I'm gonna what? I'm gonna kneel down and talk to them at their level to garner some respect. Also, look at the titles. If they were a doctor, if they have a title, use that title. Hi, doctor. Like I did some time in several VA hospitals in New York. Call them by their rank. My grandfather, my uncle, I still call him Colonel, even though he's in Army.
Well, that's something you said.
Because it's the title he earned.
Right, well, that's what you said.
Which I don't understand. He should call me doctor, but he never does. He just calls me stupid. Right? He's like my dad personified. My dad and his brothers, they all have the same attitude. So I have that. Now, what am I doing? I'm developing the rapport. And many times they're going to ask you, he goes, oh, I've seen this before. Am I going to get shocked? Because they think it's what? A defibrillator. So I have this little placard here. Oh, it's somewhere there. I put it. I had a little placard here that says what an EKG is. So you have your canned answer and say, hey, this electrocardiogram, it won't shock you. It'll actually monitor the electricity of your heart and tell us if there's anything going on with your heart. Is that all right with you? The second he nods his head and he goes, yeah, sure. Did you see in that brief 20 seconds, I not only properly identified my patient, I now identified myself. I now told him that he has orders. And then I now told him what we're going to do. He said, yes, we garner consent. Do you see all legally why that has to be the protocol? And I'm telling you, just like driving, I saw it last Friday when I was at Inova. People miss everything. And I'm sitting there and my wife's like, relax, relax. Because I've been training people for 20 years. And it goes, and when I was in this seat, yeah, I messed up. Right? But then after a while, you start learning, I got to do it the same way every time. It's annoying, but you see, every little rule has a reason. So can I also make those reasons test questions, which mirror the test questions, which, by the way, hint, hint, where do you think I got the majority of material for your exams? It's from where? RMA. Because, well, not personal experience, but RMA and CCMA reviewers. Because before, when we had We had way more students, and also, in a previous life, I was director of education in MedTech. I had what, 1,000 students? So I wrote the protocol, and the protocol had to be based on what? Practical things that you do in the world. And what's one of the practical things that you have to do in this world is pass this exam. That's why I asked that specific question earlier about the alcohol, because I saw it on every review. Hemolysis, alcohol equals hemolysis, right? And you'll see that same pattern if any of you decide to go to nursing. Everything is geared for the NCLEX and your practical abilities when you're in the world, right? So now that we got all the things that we just did is just as important as the stuff that I'm about to now do, and that should be for every procedure. So we have some students coming here to do some phlebotomy today, right? It's the same thing. When we do our little practice, our mock run, you have to say to me, hi, and you'll do the whole thing. Because if you don't, what will you do in the real world? You'll forget, right? So now he gave me consent. Now you make sure to tell him, he goes, I'm gonna have to disrobe you from the waist on up, right? And if they have your typical lab gown, you should try to cover up their stuff right here. Now, the only thing I need is this area here. Now, if you recall, it's 12 lead ECG. The limb leads are easy. So I'm just gonna jump right down to putting the precordial leads, which is V1 through V6. Now, like I said, if you just, I know I told this story a million times, but oh my God, it's been 2 years. 2 years ago, I got pneumonia, and since my family has like heart condition, it's in my family history. Of course, they're gonna hook me up to the EKG. The young lady who did it just went like this. Just started putting the electrodes, which she called stickies, right? And she's a cardiovascular technologist. That's 3 years training, right? She goes, I'm gonna put these stickies on you. First of all, am I 5 years old? That pissed me off already, right? Number two, right? I asked her, hey, because of course, you know, I like trolling on medical professionals. I'm like, how do you know where to put them on me? And then he goes, you're pretty fast, right? Because she did it this fast, right? And then she didn't measure up. She didn't do anything that we're about to show you. And she said, he goes, well, let me give you a hint. She shows me the EKG machine, goes, there's a picture on it. And then I'm like, oh, heavens to Murgatroyd, right? I just wanted to say, get away from me. But you know what? These are modern EKGs. If you kind of like put it like around here, the machine will compensate, okay? Because that's how sensitive machines are, and they're a lot smarter. During my time, when you had like, you might even see this now because it's still a reliable machine 25, 30 years later. It's called a Burdick EK10. It's like only one, you know, the old schooly ones, the one with the single strip that comes out, and you had to cut the strips, and then you had to cut and actually paste. 35 years ago when I was in MA, because you had to cut, then get some glue, and then paste it onto a special paper. And then a whole 5 years later, they had sticky paper. Ooh. Nowadays, you don't have to do any of that. This is even super old school. We don't have anything that prints out anymore. You may see it in the cardiologist's office. It goes right to an iPad. Oh, yeah, but I bet you anything, if they hooked it up, it goes right to records, right goes to EMR. Well, most cardiologists now, and also the hospital, you'll see they walk around with an iPad. But yeah, you could still use this, and then they get this, but eventually someone's gonna have to take that and scan it if you have electronic medical records. Right? Well, it's something to think about, because these things compared to the newer ones, they're relatively cheap. That setup I told you with the iPad, I know for a fact cost 12 grand. But you could see the advantages of having electronic medical records. Let's say, for example, I'm an internist, and I'm seeing EKG that's a little funky to me. I can get a wet read from a cardiologist within an hour. I email them and I go, hey, Ryan, yeah, this is me, Dr. Garais. Yeah, I got a patient. It goes, they look like they have torsades, but it looks kind of weird. And then they're like, yeah, let me look at it. And then they look, and then they call me right back. He goes, nah, he's good. And he goes, wet read good? And he goes, reply to the email, thank you. And then boop, pops on my phone. And now phone, electronic medical records, and everything. So no muss, no fuss. Back in the old days, what do I have to do? Print it out, grab it, take it to a runner, usually a medical student. They have to run all the way to the 5th floor in another building, then talk to my boy Ryan and go, hey, doctor, can you read it? And the doctor would say, fudge off. Then you'd have to sit there. Meanwhile, my patient, you know, you could see how electronic medical records makes things very, very snappy. And also, remember the purpose of the chart. The purpose of the chart is to prove continuity of care. And now with electronic medical records, there is no doubt. There's a timestamp on everything, right? So that's what's so neat, and it's really hard. I worked for an old school place for a long time, and having to photocopy and scan everything. Even back then, you're like, what is my job? And then I go, this is my job? But it has to be done, especially if there was a court order. So I'm going to show you the most correct way to do this. And the most correct way is, remember that little picture that I showed you guys? And yes, I'm going to be like that tech, and we're going to talk about the picture. But we're not going to do a picture because we're going to actually measure, because your chest is different from yours is different from mine, right? So it's all different. Now, what are we going to use? We're going to use these. These are electrodes. These are like middle of the road electrodes. I like 3M Golds. They're like 10 times more expensive than these bad boys. But, oh man, these are better than the cheap training ones. Now, gold is a wonderful, wonderful conductor of electricity. But again, I'll reassure your patient that what? That we're detecting the electricity of your heart, and it's very, very small. And he goes, and this should be painless. Now, our boy, Mr. Marquez here, right? He's smooth. What if you got a bear on your hands, right?
Yeah.
Now, the textbook says you can cut, you can shave. Do not do that. About 4 or 5 years ago, I had a student who thought, hey, let me start shaving my patient. Please. And you know what? In her defense, yes, it was in the textbook. But in my defense, on my lecture, I say, what? Don't do it, please. Right? Now, how do you do it if someone is very hairy? You put your fingers like this, you separate the hair, and then you take 70% isopropyl alcohol and just wipe, just like this. Whoop. And then when the isopropyl alcohol dies, not dies, but dries off, go like this again, then this should stick. And another thing is, many cultures love oils. So if you're palpating your patient and you're looking at your patient and they're shiny, right? Take that 70% isopropyl alcohol and wipe the areas that you need to wipe. Now, do not do this, which is another student.
Like you're dealing with PTSD
I
right now.
went to the bathroom for 5 minutes a couple of years ago, and a student had some oils, and she wanted to prevent ashiness, right? But the other student thought, let me clean her entire torso with 20 isopropyl alcohol pads. And I went away, and the other student didn't say anything, but there was a pile of isopropyl alcohol pads here, and she was like doing this. And the student was like,
What'd she think? It was a coloring book?
no, because again, you're looking at the protocol. If you look at the protocol too closely, and remember, you just need to clean the area that the electrode will stick on, right? But it was funny. I came back, and I go, you didn't find anything wrong with this? And she was like, nope. And she was like, no, I think she's clean now. And I go, she was clean before. He goes, and then he goes, please don't do that again. And it was funny because there's a pile right here. And law states that if we were doing live patients, I have a screen up, and you only call me when the results come, right? That's why you guys go in partners, right? And I step out because I don't need to see anything, right? So that's how you deal with people when the electrodes have a hard time. And if you're in a mom and pop place, they pick cheapy ones. And they either, one or two things will happen. They either stick too hard or they fall right off in the driest patient. So either situation could happen. Question?
So I had a patient yesterday that
Mhm.
came in, and she has like this skin condition, like very dry skin, and they
Like
would
eczema?
not. It's worse than eczema.
Yeah, she probably had eczema or ichthyosis when, they start peeling off. So that you have to do. You take a sterile towel, and of course, soap and water.
Yeah.
And you just try to clean off the top layers as much as you can.
Okay.
And then it goes, but don't do the isopropyl alcohol, because once you clean off that top layer, then you do the alcohol, it's gonna burn. All right, and yeah, I had that before. And also, how many times, like if you're doing this in the emergency room, blood.
Yeah.
You got to take a sterile towel. I put NSS on it, normal saline. I just dump normal saline on that towel, and I just wipe as much as I can, because my ER doc needs those things up and running. Because remember, I was EMS, and how many times EMS, our job is to put them on that gurney, and then in theory, my job is over. But usually in an urban center, I was at Lincoln Hospital. No, I was Lincoln Hospital when I was a resident, but I did St. Vincent's Medical Center in New York City that had, it's the smack dab in the middle of New York City, downtown. So we got craziness. How many times, like me and Julio would put our patient down, and then we got caught up to be part of the trauma team when we're not, because they were short staffed, and then he goes, "Hey tech, do you know how to set up an EKG?" And I'm like, I was a EKG EMT Delta, which we're trained to do this. And I go, "Yes, sir." And he was like, "Do it now, please." And the guy had blood all over him, and I'm like, so I just took a sterile towel, NSS, dumped the NSS, and and then you do what you need to do. And again, many times, even though you guys are MAs, right? You may feel, and you are the low person on the totem pole, but many times you're the only person on that pole. How many times when I was a medical assistant, I'm left with my own devices? So just use common sense and use your protocols, right? Now, another thing to monitor is if your patient is symptomatic, okay? Right, so if they're having trouble breathing and all that, so pay attention, because I always tell this story. I train residents on EKG, basic clinical skill sets, because many residents, they forgot how to be doctors. Like, for example, I had two jokers who were PGY2, postgraduate year 2, or second year residents. They forgot how to do EKGs. So they told me, go teach the PGY2s and 1s, see if they know how to do EKGs. Well, my patient was already unconscious, and then they were looking at heart block, and they're just sitting there, and my patient's already unconscious, and now about the code. So I took 2 steps to the red phone and went, "Hi, cardiac team?" "Yeah." And I said to the resident, "What room is this?" "Oh, 5? "Yeah, ER 5, please." And he goes, "I got a code in. Mayday, please. Thank you." And then he went, "Dee," and they're both looking at the machine like, and then they forgot there's a patient here. This patient was already having dyspnea, already a hard time breathing. Oh, by the way, they had the patient dead flat. Right? So now it was good that they had the patient nice and flat, because now we can put the CPR board, and now, so I bumped one of them. I'm like, let's go. Right? And then cardiac team is now wondering why the professor is doing CPR. And goes, well, these 2 psychiatric, because they know psychiatry, but they forgot you're an MD2. Right? They forgot their basic training. And that's why Lincoln Hospital every May brings me back. They bring me back. It goes to retrain residents that have forgot basic skill sets. Because, if you're a neurologist, you only deal with the neurology stuff. You forget that, can my neurology patient have a cardiac problem? Yes. Right. And they might, because I remember, for those of you who are also in my pharmacology class, remember that a lot of the anti-epileptics and anti-psychiatric medicine have cardiac effects and have blood stuff. Another thing about these electrodes, you'll see all these warnings on it. Keep it dry. Don't leave it here. How many times I had students leave it here? They're light sensitive. So after you use one set, right, you put it back, okay? Now, you'll also notice here how the machine is all nice and neat. It's called a Medusa when all the wires are all tangled. This is expensive. These little alligator clips, they're cheap looking, but you can't buy them separately. You have to buy them in a pack, and the pack costs $140 plus, and that's the cheap stuff. Odds are, if you're in a cardiologic center or internal medicine practice, they're gonna buy the good stuff, which can run up to $500. So this thing shouldn't be dangling. Because if it does, these things crack and they break. Another thing you also have to check is these electrodes, they're sticky, especially the cheap ones. And you can get a lot of schmutz in here. I used that word twice today. Isn't that neat? I'm using Yiddish words now for medical terms. But you get a lot of little sticky stuff like this. That sticky stuff will then give you artifacts. You're going to get wandering baseline. And then you get a wandering baseline. Is that a good read? Nope. Right? So you got to make sure these are clean. And you can see here, the seniors before you, nice and neat. None of these running around. Another pet peeve I have, when you take these out, do you stick them on your patient to hold? No. How many times I've seen them in my patient's hair or in here? Because they put them here, the tech puts it here, so the patient turns, and then they wake up in the morning like,
Where'd that one go again?
yeah, and again, what are you doing to the dignity of your patient? It's a mockery already. Because remember, you guys say on day one, I want to help people, yeah? But then they forget protocol. Talk to the nurses now that they're in the clinicals. A lot of them have decent clinical experience, but now they're in there as nurses. They're like, man, I'm messing up all over the place, right? I thought when I was a CNA, I knew what I'm doing. No, you know what you're doing as a CNA. When you go in as a medical assistant, that's a different ball of wax. You go in as a nurse, it's a different ball of wax. You go in as a resident, like me, I already had almost 10 years worth of clinical experience before I became a physician. And my first day as a resident was just as horrific as my first day as a medical assistant. No, actually, I take that back. My first year as a medical assistant, they only let me answer the phones. They totally even didn't trust me to even be in the back room. I answered the phones, cleaned the beds. I pretty much was a janitor for like the first 8 months, right? But then little by little, they started trusting me like, hey, this guy comes in on time every day. He knows what he's doing. Hey, do you know what this is? No. I goes, oh, that's a pulmonary function test. Let me show you how that works. Hey, do you know what this is? Yeah, it's an EKG, but I only touched it once. Because remember I shared with you guys, I went to some diploma mill that got shut down. The state shut it down. And it was one of those, welcome to the class of next Tuesday, when you had former MAs who probably just graduated 6 months before you be your professor. But here, who's your professors? Look at all your professors. They're all terminal degree. Actually, that is now a new rule as of 2020. We only accept terminal degree professors on this campus. I challenge George Mason, George Washington. I challenge any of these schools to prove to us the entire staff is terminal degree. Look at all your professors. They're all DNPs. And if they're not DNPs, they got double masters. Right? And the second masters is what? Education. Right? So that's why I'm always promoting like good small schools like us. And also, where are you going to get an MD for 3 of you? And you just made an appointment. You can come in whenever you want. So now that I have that, we measure up. Now, how you measure? Everyone touch their right collarbone, also known as your clavicle. You feel that? There's a notch. And for those of you at home, touch your right collarbone, right? And then there's a space right underneath. That space is your first intercostal space. And if you remember the chart, you could feel your breastbone here, which is your sternum. I'm feeling on the right collarbone, right? First intercostal space, bone. Second intercostal space, bone. Third intercostal space, bone. Fourth intercostal space. Now, don't do this, what I'm doing, because there are artery, veins, and nerves in your intercostal space. If you poke too hard, it's painful, right? So you have to be firm, but not enough to I can move my patient. Okay, so I'm feeling it right there. So I feel it with my finger, and then I look on the skin. Oh, that little blip right there, that's what I'm going to put. Now, everything that I'm going to put on the chest, right, the tabs have to face down because I'm going to put the hub, or this thing here. Now, the textbook says is to put it around here, but that's near his junk, right? So what's going to happen? If I put it here and I accidentally touch that, we have a nice little lawsuit on our hands. So I like to put the hub or the place where all the wires meet right here, right here near their hip. But you want the tabs facing down so that the wire doesn't back in on itself and then come out. Okay, so that's fourth intercostal space, right sternal border. Now, I already measured down fourth intercostal space. Do I have to measure down again? Nope. all I have to do is go directly across to fourth intercostal space, left sternal border. So that's V1, and now that's V2. And notice I only used 2 electrodes thus far. Now, if I'm going here, I skip V3, and now I'm going to go to bone, next space, which is fifth intercostal space. But I have to do mid-clavicular line. So his clavicle's here, so this mid, and I know here, so I'm going to put it like here. Right? Now, I did V1, V2, V3, V4 is what? Fifth intercostal space, mid-clavicular line, because your collarbone is your, your collarbone is your clavicle, right? So I'm here. Now, the answer on every EKG exam, where is the location of V3? The location of V3 is always in between 2 and 4. So what can you do? You can see how challenging it is now with gloves, right? So you see how it's like starting to form an arch? Then you have fifth intercostal space. So I know this is 5, right? I'm feeling the space, feeling the space. Then I go to the anterior axillary line, right where the crease of my armpit. So I'm following that contour. V1, 2, 3, 4. This is V5, fifth intercostal space, anterior axillary line. Now, where's your mid-axillary line? Let me remove his arm so you can see. Right? Now, your mid-axillary line is in between what? The bottom of the bed and the top of his chest. So it's got to be where? Here. And again, fifth intercostal space. So I'm going to put it here. And do you see how it forms a little arch?
Yeah.
It's just slight.
Kind of like down.
Right? I've had people do craziness, and it came out. And then I have people, they like do it by eye. Even my mother. Last time, my father-in-law needed an EKG, and I was taking his blood, and we were here. We were like, that was at the time before we got all his immigration papers knocked out. Oh, am I recording on this? Well, it's okay because he's got papers now. Okay, so right, we were here. It was his first year here in America, and I'm like, man, we don't want to go to the hospital. I can do everything here. So we did. We took bloods. We did EKG, and me and my mom were here helping out my father-in-law. And this is how my mother did. Blah, 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 blah. But you know what? Years and years of doing this, right? She measured up the first one and then did what? Because here you see the arc is very subtle. Because if you look at your rib cage, it's subtle. Now, here we have a non-obese patient. It gets tricky when it becomes female and you have a lot of breast tissue. Now, how do you deal with that? Well, if you know and understand what these things are, this is a camera pointing where? Here, 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 here. So if you have breast tissue, right, it goes, you can put it on top of the breast tissue as long as it's pointing where? In the direction of this, towards the heart, right? So also another.
It's good to memorize in a way for something like
yeah,
that.
so that's why you measure up so you can have an idea. But when there's breast tissue here, it gets a little bit more tricky. But again, like I told you, right? Because sometimes if you have massive breast tissue here, right? If like, you know, they got D cups or something like that, sometimes the tech puts it down here. But if the tech puts it down here, where is it pointing? Pointing up. But like I told you, a lot of the modern EKG machines that are made in the last 10 years will compensate for it. Or when I plug it in, it'll go dee, 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 and it'll tell you something's awry. And then you just move it. Another trick is you just move it until the beeping goes away. When I was a medical assistant and I had a really big woman, or even, let's admit, there's some guys who are, you know, got some good C cups on them, right? So this is what I used to do. I used to move around the electrode, plug it in, and when it stopped beeping, we're good to go. That's a nice little side trick, but again, most modern EKG machines will compensate.
What about implants?
Now, implants and, that's a good question. Implants and nipple rings.
Oh, geez.
Nipple rings, we did an experiment at MedTech because for whatever reason, out of a class of 40, I had 6 students who had nipple rings. So we wanted to see, and also we called the AAMA, the American Association of Medical Assistants, to see what was their take on it. And they said that it shouldn't affect it, and it didn't, unless the wire was touching, because we were wondering, like, you know, just like how we have to remove watches or anything that might be metal. And also, they did a lot of studies on patients who already had defibrillators. And you now know from the exam is, if you have a defibrillator, it'll show a little spike. And that's a little big metal thing. So that little metal stud that's on the nipple shouldn't be too bad. Shouldn't be too bad. And implants as well. I've had a lot of patients, a lot of students that had implants. It did not affect it. And you know, the implants, many people don't get the really big ones unless you're in porn or something, right? They had their breast tissue was very stiff, and it made a nice contour for to point the electrodes, and that's my experience, right? But the hardest ones were the patient's semi-obese, or the patient has pendulous breasts, like they're older. But then, if you know and understand what these things are, you can kind of place it in the proper place. So this is the hardest thing to do on the EKG.
Yeah.
And so that's the thing you're practicing today, this part.
Well, like you said, as long as you measure it properly. it should be
Yeah.
fine.
And did you see, did it take too long for me? I only had to measure it once.
What'd you do?
So
That's
actually,
weird. Yeah,
when
question.
I first did one, I did it just like this at the office. They told me I was doing it wrong.
Why? What?
So literally, the ones on the side are like lower and they're
Okay, there's also, this is the most correct way, but that brings me to variation,
okay.
right? And especially with the limb leads. There are other schools of thought that they take some of these. Let me turn this darn thing on.
Yeah, you broke it.
I didn't even turn it on. Why? It's the poltergeist. Remember I told you guys? Yes, okay, thank you. Right? What do you call that? It goes, there are some schools of thought where they take the lower leads and put it more abdominal. Remember, I teach you the textbook way. It goes based on different machines and different systems. There are other things. And actually that got my one of my other students in trouble because she said, well, Dr. Garais is a doctor, he's an internist, and he told me that's not the way you do it. No. This is the most textbook correct way. But when you're in your facility, different machines, different things, and also they may want, it goes, a different viewpoint. Remember, because this is what these things are cameras. But typically, where's your heart? Is here. Where should these cameras be pointing? Here. Right? But there's other, like I said, there's other machines. Now, let me show you some variations regarding, where's his arm? Okay.
Just put it right there.
Right? So here, when we're doing limb leads, right? Typically, you put it where? Here in the deltoid, in the fatty parts. Now, this is what we know for a fact. If you put it on the bony parts, it dissipates the signal, which is not good. So not on the elbow and not on bone. You can even put it here. Some places even like the volar surface of the arm here. Now, for the feet, right, there's a lot of variation. I like putting it down here in the gastrocnemius, in the belly, right here. Other people like putting it on the lateral thigh. And you can even put it here in the lower abdominal quadrant on their hip. But make sure it doesn't touch their ischial spine. Like, you know, like make sure it's like on the meaty part, right, of their lower abdomen, right? But you could see, even if I put it in the lower part of the abdomen, will it still form a triangle? Yeah. You should still be fine.
Right. Well, I mean, even going to school, a lot of teachers will tell you, you just learn the basics here so you can learn whatever you're on.
Yeah, and also there's different protocols. And let's say your doctor's doing it wrong. Guess what? That's the guy or gal who's paying you. Like, I remember, you guys will notice I keep on mentioning certain names as my bosses, right? Because they were my worst bosses, and I remember them like it was yesterday, right? My best bosses, like Dr. Esadebe here, like I'll never use her as an example. She's a really great, nice person. But Dr. Cassidy, I'm waiting for the day to dance on his grave. Someone told me he got sick, and I'm like, he got COVID? Oh, I'm going back to New York. I'm gonna pay that son of a beehive a visit. He was my attending, and he made my life hell. And he told me day one, I know you don't belong here.
Fun time.
And he go, and it's funny, when I left, he goes, you sure you don't want to leave? What a jerk, right? So if you notice, if I have 4 limb leads and 6 chest leads, that means I should have 10 of these. So when I grab up all of these at the end of the day, I should count 10. So those of you for EKG, that's our lab. Take some of these and you can practice, and then you can call upon me if you want me to go check, but you guys can also look up the locations. And again, this is the most correct way. And you could show us how they trained you, and I could tell you, yeah, that's a variation. There's so many variations on doing this, but remember, especially you go to your externship, whatever they say their protocol is, you follow it, because you have to follow the letter of the law. And don't say, well, Dr. Garais, please don't say that, okay? Because I have a good relationship with these. You guys don't know the things I have to do to get externship sites, okay? So guys, practice this, and here's some extras. Now, like sometimes you always get extras or whatever, like this. I like putting them in like a nice little envelope. And remember my adage regarding equipment. 2 is 1, 1 is none. Always have your backup. So I like putting an extra set, especially I know I'm doing EKG. Or if I have the drawer, I've got an extra. Like any cardiologist office worth their weight, they've got like a drawer full of extras like this. Okay, so guys, practice that, and then you do it once or twice, you should be good. And once you guys are ready, after I do some phlebotomy with her, I can sit in there and you can do an actual. And again, I have to stress, the COVID protocol says I should not be doing this, but it goes, I am low risk. I do not have any, I have to say it right here on video. I goes, my last test was several months ago. I'm negative. I'm no longer a clinician, and you guys will be touching me as if we were touching me in the office. And if you would like to also have a shield, we have shields available for you. That's if you want to do it. It's mandatory to play with this thing.
Okay.
Optional if you want to take a real EKG with me in the bed next here after you mess with this thing. Okay? All righty. Have at it. Okay, now, for those of you at home, if you want to watch the... All right. So now you know EKG. So now,
Yeah, definitely tell me that.
you and I, because we'll...
So you work in a specialty office?
Whoa. Okay, sorry if I'm making you a little bit dizzy.
What do you want me on that side?
Right here, I'll demo it, and then...
I don't even want to learn. So kind of you to let me tell me.
Hello. And this is phlebotomy. And you could see, I'm going to set up the equipment here. Okay, and then I'm going to do a demo from beginning to end. Then you could be good and you can log off. Okay, so at least I know how this is, of course, being recorded, and I'll keep this so you can look at the protocol and compare it to your the protocol that's in your Moodle.
Right.
Okay. So let me, of course, I got to always glove up and I always got to wash up. So let's pretend I did that.
Okay.
And again, back to the thing. You have to introduce yourself, right? You have to, now,
Yeah, for me, when
in real life,
I took
if we're doing this in real life,
EKG,
mask isn't enough. You have to have your visor, okay? Because this is bloodborne protocols. But again, this is, well, you know what? Even in simulation, let's pretend. Let's do what we really do. Well, you have one. You brought one, right?
Yeah, I broke my mind.
You're good. We'll get y'all fixed up.
Here's one disposable. This is a disposable one, right? And then, of course, you can lease it out of your package, and then I could wear it. But of course, it looks a little bit opaque. But right now, for training purposes, right, I'm just gonna take mine off.
Yeah, I'm looking at it like.
that is how important the protocol is for bloodborne pathogen, especially in during the quarantine during COVID. So you're good to go. You're ready. Oh my God, these gloves are so bad. Now, one of these things is, like, you can look online on all these tricks to make your glasses not fog up, but I had to give in, and I bought on Amazon one of those special sprays that coats your glasses, and it works the best, and it's only like $8. So because a month ago I started getting irritated because I can't see, and I got to wear my and now we have a protocol here at Stratford where even if I'm at my desk alone, I have to wear my mask because you're breathing in, right? And right now also the protocol states, like, I'm with lab with you guys, but after lab I got to get out of here. I can't stay, right? Because it's a closed area. But here we're in healthcare. We can't dictate where we get to say, where we get to go. So let's look at our equipment. We have, of course, our tourniquet, and if it's usually blue like this, it's latex free, but make sure you check the box. Now, typically you can use this up to 3 or 4 people, and then you discard it. Now, one way to clean it, let's say you got some little skin cells or something from your previous patient. Again, you take a 70% isopropyl alcohol pad. They're taking the money, right? And then you open it, of course, and then I just like this, and that should be good enough, right? So now the hardest part, and the thing that you should practice at home, is feeling the vein, right? You got 3 choices. You have your median cubital, and then the one here on the thumb side, that is your cephalic, and the one here on your pinky side, that is your basilic. Those are the 3 main ones you can hit. Now, there's called accessory nerves that can hit a little bit further down, but your primary objective is here, in this little depression here called your antecubital fossa, right? Know these things because they're on exams, and also, when you're talking to another professional, you don't say, "Oh, I'm gonna hit them right in the bumpy." You want to sound like the pro. So antecubital fossa, I know what vein I'm hitting, right? I have my tourniquet. Now you'll notice that I have tubes, more than one. And because back to my adage that I mentioned a minute ago, 1 is none, no, 2 is 1, 1 is none. So what happens if I'm only carrying 1? If this thing is bad, what am I going to do? I have a needle here and I go, "Excuse me, Mr. Brown, I'll be right back." And honestly, I did that when I was an MA. It's embarrassing, and the patient's going to get pissed off. So I have that. I have sterilized gauze sponges, either 1 by 1 or 2 by 2. They could also be in a pack. And remember, don't dig your grubby little hands in the pack. You always have a gloved hand, right? But here, I have these, and I open it up, if you recall, right? You got to open it up, and it's more challenging when you have gloves on. Right? You open it up like a banana. This. Now, it's neat because, is this thing sterile? No. So I can put it here. Now, I'm right-handed, so I'm going to be poking with this hand. But where do I put my equipment? I put it here. So I have this. I have my prep pad. And you see how I ripped it open and I got it ready? And I have it in there. Like that. So that's ready, that's ready. I have my backups here. Now I'm going to need to assemble my needle holder and needle. Needle holder. Oh. So these are your needles. Do you see the green color? That means it's 21 gauge. So this is your typical gauge for your, yeah, I'll deal with it.
Okay. I'm sure he's
He won't die.
Not yet.
We won't let him die. Maybe. And if he dies anyway, I'm just going to diagnose him COVID. And then get some more funding from CMS and the Department of Health. Yeah, like all you guys know, I lived, grew up, and worked and practiced in New York City.
Yep.
Everyone talk to any clinician who works in New York City. They're like, a lot of the patient overflow is due to fear.
I know.
It is not
I
due
told-
to
I
the
told my
increase of
family members that.
diagnoses. It is fear. And also, what happens when everyone knows the hospital might give out free vaccines or free whatever?
Well, let me ask you
Everybody and their
something.
sister is going to fall in line.
Let me ask you something. An 87-year-old woman with dementia who never leaves home, should she get the vaccine?
Well, it's right now, me personally,
With bad dementia.
I
she
need
doesn't even
I
know
need
what
to see more data regarding the vaccine. Once we
Mhm,
start
thank
getting into
you.
millions, and also if I were like my mother, like of a more advanced age, I am not going out. I will stay home. I will keep my contacts low, and that's what my mother does.
The biggest risk she has is the CNAs that come in to help take care of her.
Yeah, and that's really rough. And for medical healthcare professionals, our greatest thing is our stress level.
Keep blood on me.
Right? Our greatest thing is our stress level.
Yep.
So right now, I can tell you right now, because everybody who got COVID, all 8 students in the last 9 months who got COVID here, when I interviewed them, because I have to also make sure that they have, negative results and they can come back to lab and whatever, which by the way, not a single one of them came back to lab yet. They all are opting to take their online lecture classes first until all of this is all over, which is nice of them to do that. But they all said the same thing. Hey, I followed my PPE. I did everything. And oh, by the way, all of them have kids. None of the kids and none of the elderly family members got it. But they got it because point source was where they work. And then when I interviewed all of them, I go, how many days of work you worked? Oh, 6. Oh, that's when I did my double. It's the stress, right?
Yeah.
Stress lowers your immune system, increases your cortisol, and then what happens? You catch it.
Yeah.
Now, remember, back to why we're wearing the mask. Because the 249 other things that can do harm to me in this room, this has to protect me from it, right? Like bacterial, dust, and all these things. And also, right, having watching my health, and like if I feel like the other day, I just had a little cough or a little whatever, what I do, sleep early. I started eating some fruit. You guys know me. You guys already know a little bit about me.
Yeah.
Unless it's in a blender and it's got rum in it, I don't eat fruit. But now that I'm getting older, I'm trying to eat a little bit better. I actually ate salad twice this week. That's insane for me.
Salad with mahi.
Oh, I'd love mahi, but here's my problem. I wanted grilled and I wanted with Java rice, which is really bad.
Yeah.
And also I can make a nice gravy for it, and I drink beer. So these things are not conducive. Oh, I'm describing to you exactly what I ate like a couple of years ago when last time I had mahi at a restaurant. It's the mahi was okay, but all the other garbage that I'm eating with it, that's not good. Okay, I digress. So here's our equipment. Now, do you see this orange thing? That is our safety guide, right? So I got everything all set up, right? Right-handed, and since I'm right-handed, this will be my anchor or my sticking hand, and my left hand will be the hand that will be giving me equipment. So you could see, if my patient stuck their hand out here, my right hand is the sticking hand, and the left hand will be the transfer hand. So that's when I can do multiple tubes. I can do everything here. And this thing is an anchor. What does an anchor do? Boom. And another.
I anchor like this. I try to put my
Yeah, and then you put your hand like this. So if this guy moves, then I can not only feel it, I can also prevent, like, hey, Mr. Brown, oh, right? And then you're like, oh, okay, sorry. Because, the patient could be anxious and they just want the procedure over. So now that we have all of, now we have all our equipment. Yeah, I do too, because I got stuff to do.
Yeah.
Right? And so we start from the beginning. Hi, good afternoon, Mr. Brown. My name is Nelson. I'll be your tech today. Let's give you another doctor, a nice one. Dr. Duranlis wants me to take some blood from you, and I got to take it in these tubes. Is that okay? And then he rolled up his sleeve and he nodded his head. So now I have consent. Mr. Brown goes, I need to confirm your date of birth and the last 4 digits of your social. Okay, wonderful. That's great. So I check on the chart. Now, when you tie, you have 60 seconds. Now, when I tie, I cross over like this, right? And then after this, after we do the demo, right, you're going to tie on my arm, my real arm, and I want you to search. for the real vein before we start playing with this. But here, for the demo purposes, I pull on this one, the bottom one, right? And we're holding this, and that's the one I tuck. And you see, if you do it that way, right? Do you see how the bunny ears are away from the antecubital fossa? Yeah. So now this can't contaminate this area. Then I take the isopropyl alcohol pad and I do concentric circles. And you see how exaggerated, how big I put it? Because remember, my primary is what? The median cubital. But do you think I might want to find a cephalic if this is no good? Do you think I might want to find a basilic if this is no good? Do you think I might want to find an accessory vein if these aren't no good? So I exaggerate it. And you notice I don't go over the same real estate twice. It gets bigger, 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 and then, okay? And then I put that down. Okay? Now I put that down, and I put this here because I'm going to need that in a minute. And I'll show you why. So now I assemble all my equipment, I small talk, right? Because remember what we mentioned earlier today, I can't stick because this is still wet. You see how it's shiny a little bit is? So I don't want to cause hemolysis because if I stick my needle and this alcohol goes inside this needle, it's going to go inside the tube and then we're going to have a problem. Now remember, when I'm taking two, I have a tiger top and you see the gel and you know this is an SST tube and then you have a lavender tube. From the order of draw, which goes first, SST or lavender? Bingo. Lavender and then SST. And then I have my backups, right? So if you have one of these little racks, use them. But if not, make sure like when you have a mayo tray or whatever, that you put like some sort of chucks or something so that it doesn't roll away from you, especially on a flat table like this, right? I've had that happen to me a million times. Oh, another thing I also forgot, that I always forget.
Sharps container.
Sharps containers, right? And how do you know it's Sharps, right? It has the biohazard symbol, and it'll say the word Sharps, and it also only to this level. You never fill up one. And what genius put? If I could show you, you only put Sharps in here. There's a whole bunch of wrappers in here, gauze. Hey, wasn't my class. Something to talk to somebody else about, but it was not us, right? So if I have like something blood soaked, it's going to go in the biohazard, but not the Sharps. What only goes in the Sharps? Sharp things, right? So let's start. This is already dry. I already did my my small talk, right? You can put that on the side. So I'm like this, right? Remember that little gauze thing that I had extra? These aren't sterile, but if I go like this, makes it a little cleaner, right? Then I can go palpate to make sure I know where I am. Oh, here it is. Ooh, juicy. This guy works out, right? So now I know it's there, right? What can I do? I get my tube. Who goes first? Lavender?
Lavender.
Right? I get my tube first. And do you see how I cradle it? I don't put it all the way in, because if I put it all the way in, it's going to start sucking in air. I only put it all the way in when it's in vein and when I'm getting blood. So I'm here. Hopefully, well, whether we get blood or not. Now I remove the cover. I can move this thing around because I want, do you see how it, like the hole is up?
Yeah.
That's your bevel. And you should hit bevel up at a 15-degree down angle, right? So it's, you know, it's not matching the level of the skin, but yeah, it's coming close. I anchor with my non-dominant hand 2 to 3 centimeters underneath of where the hole is going to be of my puncture. So bevel up, I go in and I go in, whoop, just like that.
And when you put your hand on it like that, you pull the skin taut at the same time? Or just...
Not really. I just hold it down because if I pull it down, it might move the vein,
Okay.
especially with my more elderly patient. Then, and boom, I let it fill, right? And then now it's filling up with blood. What do? Tourniquet out. And you see how I make sure it falls wayside. Now, since it's lavender, it has an EDTA, I have to do my figure 8s, 6 to 8 of them, like this.
I thought it was 8 to 10.
6 to 8, 8 to 10, 10 to 15. I've been saying 6 to 8 for 20 years. It's probably 8 to 10. Some books 10 to 12. But real life, people do it like 2 or 3 times, and they put it in just enough to see. They have to mix the blood. Now, SST tube, does it have to mix? No, because this thing, I want it to clot because it has a clot separator here. So you notice my anchor hand hasn't moved this entire time. So you can take your time.
So when you're changing tubes, you have to have the tourniquet off too?
Yeah, you should, because so the blood will flow, because if not, the blood will flow real, and then boom, right? And then I don't have to, and I just put it nicely like this. Now, you see how I can take my time?
Yeah.
Because my anchor hand, right? And it's venous blood. Even if I let go right now, it's just gonna ooze out. Now, the textbook says I could put my gauze, you know, you wrap your gauze like this. You can put your gauze right on top of the needle. I learned in EMS, not a good thing, because you're in a moving vehicle. I like doing like this, putting it far away. And you see, I'm also now holding my patient's arm, so because your patient's gonna be anxious. They're gonna want to move that arm. Mr. Brown, we're almost done. And watch, I'll do it slow. Out, down. Mr. Brown, can you hold this for me, please? And he'll hold it. Then I walk away from Mr. Brown. I find a hard surface away from my patient. You don't do it like this. You don't do it like this, right? You don't do it like this. And I've seen all of it. You find a hard surface away from your patient. I step away, right? Click. Now you see? Can't hurt anybody anymore. Then I have to do what? Get rid of it. Now, this stuff is blood. You got to treat this like it's your life, because it is your life. And also, we have to treat it like it's what? Toxic waste. Because remember, the universal precaution states that everybody in the room has HIV. Everybody in the room has hepatitis. And I'd be more worried about hepatitis than HIV, right? And so when it's done, right, you have the gauze here. Hold for 1 minute and then check, right? Is he still bleeding? Now, if he's still bleeding, I got to get another gauze, and I do not remove this initial one, because if you remove the initial one, it removes the platelet plug, and then my patient's going to start from 0 and bleed again. So even though this is soaked, get another one on top of here. Now, if for 1 more minute that the patient's blood isn't controlled, you have the patient raise their arm with the gauze here to apply pressure for 1 more minute. And if it's still that doesn't do it, you document it, call your chain of command. And act like it's nonchalant, because it is. Odds are they're on warfarin, they're on Coumadin, or they took, well, like, I had a patient like, oh, I forgot to take my aspirin. And then I asked them, how many did you take this morning? 3. And you're like, okay, that's why your blood is coming out like it's water. Okay, wonderful, right? But I'm exaggerating, but just know that that is the last part. And again, just like EKG, pay attention to your patient. If they look faint, they look like they had a vomit. How many times an EMS patient vomit on me because I'm not paying attention? And then after my rookie year, I learned, oh, he looks a little bit green. Sir, can you move your head this way? Thank you, right? And then second year in EMS, a lot less patients vomited on me. Or if they're angry, sometimes they want to spit on you or they try to bite you. I got bit twice the first year. But second year, no one bit me. Why? Because then I learned, and I'm now paying attention to my patient, right? So after all that's said and done, right, I take the things that I need to take, and then I remove them. Now, here's another old school thing, but that maybe you might see in the real world. Sometimes you can use these barrels like 2 or 3 times as long as there's no blood in it. So let's say I use this barrel and then I want to reuse it, right? I capped it. I did what I had to do. Now I have this. If you guys notice, you see this key thing here? Looks like a little key. You guys ever wonder? Do you guys ever wonder what that thing was for?
You break it up, don't you?
No, you don't break it. You just put it here, right? And then you do lefty-loosey.
No.
And then, doop. Because I used to work as an MA for a very, very cheap doctor. And she made me use these blanks as much as I can. But nowadays, I just wanted to show you that. But in real life, you discard these. But you might see it in a lot of old school people, and also I'm telling you, a lot of office managers try to make ends meet, because a good manager treats their office like it was their own. When I was an office manager, how many times I had one set of toilet paper for the patients and one set of toilet paper for the MAs, and how many times the MA on bathroom break, hey, just wash. Don't have to touch that. You don't, because we have a bidet. You don't have to touch that with paper. You know how much paper costs? And then my MAs used to get angry at me like, you one cheap son of a beehive. And I'm like, yeah, me being cheap, you get paid, right? Me being cheap, we can get really important things like meds, free meds. And also how many times where, you know, a lot of doctors' offices hate drug reps. I don't. I court drug reps and they become my best friends. Why? This is not quite legal anymore, but when I was a medical assistant 30 years ago, I used to take all the samples, put them all together, and for patients who couldn't afford, I could at least give them a couple. I would have these little packets of drugs, at least give them a couple of days, so that maybe they can fix their insurance or do what. And let me tell you, it's illegal, but I know a lot of doctors' offices still do that kind of thing, but it's illegal, because remember your pharmacology. If the label says for sample use only and only has one tablet, can I put 12 tablets in that bottle? No, that violates FDA label laws, right? But I'm also providing you guys the things that you may see that you might like, that's fudged up,
Yeah.
right? But it's
Like
what,
you're telling us not to be surprised.
yeah, don't be surprised if, you know, the doctor goes, hey, take all these pills, half of these throw in the toilet, and the other half put in these bottles. And you're like, what? And then you're like, okay. Or how many times, because the proper way to dispose of pills is you put them all in one bucket and you let it in the water for days and it melts like a slurry, and then scoop by scoop, you flush it. But stupid Nelson, M.A. Nelson, tried to, what do you call that? I poured it out into the garbage, and then I got in trouble for that. And then another time I put it in the sink, and it was a normal sink, and then I clogged up the sink. All right. Again, 20-year-old Nelson, not too smart, right? But my stupidity gets to be your nice, lovely story, and also it gets to be your opportunity to live through my mistakes, so you don't get to do stupid mistakes. Okay, that's it. Miss Bates, thank you for stopping by. You have credit for today. And again, my offer still stands that, you know, when all of this is all over, you got some time to do some one-on-one, stop by the lab and we could do this, okay? Live. All right, have a good one. Signing off.